last time he went back to India, it was a prolonged period of time because it was a family emergency. And he did not take malaria prophylaxis at that point. So because the physician notified that in the history of present illness, they did blood work that determined that the patient had malaria as indicated by the presence of protozoa in the red blood cells or the erythrocytes. Right? And that coupled with the fact that he had symptoms diagnosed with malaria. So after we talk about the lecture presentation, we'll go back to this case and see if we can answer some of the questions that I have surrounding the information. So some of the statistics behind malaria. This protozoal infection is the most common in terms of this type of infectious disease. It's associated with the most common parasitic infections. So the World Health Organization estimates there's about 350 to 500 million cases of malaria a year, which is huge. Right? And the number of deaths are about 1 million worldwide, which is also very significant. And the cases in the United States are far off less than the 300 and 500 million worldwide. And we'll talk about the cases here in the United States because this country is not considered to be what we call endemic, meaning that if a patient travels to the United States, you don't have to prophylax against malaria. Right? But if the malaria is diagnosed and treated rapidly, it's pretty much self-limiting, meaning that it won't result in any type of mortality. However, if it goes undiagnosed and untreated, you can end up with these types of manifestations which are listed here. So renal failure, pulmonary edema, coma, seizure, and death if it's very, very severe. Okay? So in the United States, if you look at the statistics here between 1999 and 2008, there was over 8,000 cases of malaria. And of those, 43 were fatal. Okay, so it's not as significant as the worldwide statistics, but it's still pretty much indicative of the fact that we're still seeing cases here in this country. And this is primarily due to patients that immigrate to this country or internationally travel and then bring back the malaria to this country. Right? So as you can see here, there is considerable variability country by country in terms of the transmission rates of malaria. So generally, the areas of the world which are considered to be endemic include Central America as well as South America, most of Africa, most of the Middle East, and Asia and the Philippines. Northern America is considered to be a non-endemic in terms of malaria, including Canada. Europe is considered to be non-endemic, as well as Russia. So if you're traveling in those areas, you will most likely not receive any type of malaria prophylaxis. Now, what makes this more difficult is that depending on the country, there may be pockets of areas within that country which are not considered to be endemic for malaria. So you don't really memorize this information. What you do is, and I'll talk about this, you go on the CDC website, and there is travelers' information regarding malaria. And what you do is you just type in the country and the specific area in that country where you're traveling to, and it'll indicate what type of malaria prophylaxis you need. All right, so I'm not going to have you memorize all the different countries of the world and whether you require malaria prophylaxis unless you want. I want my slashed in the parking lot. Okay, so the genus that causes malaria is known as Plasmodium. And there are different species of Plasmodium which are listed here. There are 4 major species, which is falciparum, vivax, ovalis, and malaria. This species here is pretty much newly defined and is limited at this point mostly to animals, although you are seeing some sporadic cases in humans. But generally, these are the 4 major species listed right here. And how is malaria transmitted? It's primarily through an infected Anopheles mosquito. Okay, but there have been cases of transmission that are listed here. Blood transfusion, organ transplants, IV drug abuse and needle sharing, as well as fetal to mother to fetal transfer of this infection. Okay, so this is rare, but it can occur. Most likely, like I said, it's due to the infected Anopheles mosquito. Of all of these species that are listed here, this one, number one, the falciparum, is considered to be the most dangerous and widespread. And it's this type of species which can lead to these manifestations here. Okay? Now, the primary goal when a patient is assumed to have malaria is to do what we call rapid diagnostic testing. And how we will diagnose malaria is by blood smears. So we'll draw blood, and generally you're going to be drawing blood over 3 days. So every 12 to 24 hours, you're going to be drawing blood. And the reason why is because you want to test to see if there's any protozoa in the erythrocytes. So if you don't do frequent blood draws, you may miss them. Okay, so if you look at this blood smear here, it identifies what we call the merozyte, and we'll talk about what a merozyte is in terms of the life cycle of the plasmodium within the erythrocyte. So this smear, if you look, there's only 1, 2, 3 erythrocytes that are infected. So that's why if you don't do frequent blood smears, you may, like I said, miss that diagnosis. And the blood smear is important because it not only identifies, which is let's get a degree of the parasitemia, but also it'll identify the specific species that the patient is infected with, which is important because that'll determine, in some respect, what treatment options you're going to be giving these patients. Okay? Yes, it replicates. It replicates over the course of a couple of weeks. And there's different replication processes. It replicates first in the Anopheles mosquito, and then it replicates in the host. All right, so we'll talk about that. So this is the life cycle of the Anopheles mosquito and the parasites which are infected with the mosquito. So what ends up happening is that once the Anopheles mosquito becomes infected with the protozoa, its primary species in the life cycle first is known as a gametocyte. So gametocyte is the first stage of the life cycle of the malaria protozoa. So once the mosquito becomes infected with the gametocyte, it's going to replicate within the salivary glands of the mosquito. And it's going to become what we call a sporozyte. Okay, so the gametocyte is the first stage, and then it's going to replicate into what we call a sporozyte within the salivary glands of the mosquito. And this sporozyte is what's eventually going to enter into the host cell, which is both going to be infected by the Anopheles mosquito. So this host cell could be either a human or it can be an animal. And so the sporozyte then enters into the human, and the target cell for sporozyte replication is going to be the hepatocyte. The hepatocyte is the chief cell of the liver. So once this sporocyte cell enters into the liver, it becomes what we call a schizon. This is all listed here. This is a schizon. So don't get nervous. I can see it already in your faces. So once it becomes a schizon, okay, now it's in the hepatocyte, it remains in that hepatocyte for a period of time, depending on what species the patient is infected with. If the species is the falciparum, or the malaria, or the noelsi species, it's going to remain in the hepatocyte for about a few weeks. If the patient is infected with this Ovalis or Vivax strain, it can remain in the hepatocyte for months. And that's very, very important. I'll talk about the significance of that. If the patient is infected with either the falciparum, the malaria, or the noelsi species, it's a few weeks. If it's the vivax or the ovale species, it could be a couple of months. And that's important, and I'll explain why that is important. Okay, so depending on the species that the patient is infected with, the schizon is going to eventually what we call rupture. And once it ruptures, it could either become what we call a merozyte, and the merozyte is basically what's going to infect the red blood cell. So it could either become a merozyte, or it could just become another gametocyte and hang out outside of the red blood cell to be picked up by new Anopheles mosquitoes and further infect other patients. Does this make sense? Does anyone have any questions on this? Yes.
The gametophyte won't enter the blood, right?
I'm sorry?
The gametophyte won't enter the blood.
The gametophyte will not enter the red blood cell. Correct. Right. It stays outside the red blood cell. So what stage of the malaria enters into the red blood cell? What is it called?
Merozyte.
Merozyte. Very good. Now, what species remains in the hepatocyte of the liver for a prolonged period of time?
Schizon.
Well, schizons is basically the cell that enters into the hepatocyte, but before it ruptures, right, it could remain weeks or it could remain months in the hepatocyte as a schizon. So what species remains as a schizon for months?
The vivax.
Okay. The vivax or the ovale, right? And the other species can remain as a schizon for weeks. If it remains what we call dormant in the hepatocyte, it's coined this term here. Here, a hypnozyte. So if the species remains dormant in the hepatocyte for a prolonged period of time, which is primarily the vivax species and the ovale species, it's termed a hypnozyte. Okay, so you have the gametocyte, the sporozyte, the merozyte, the hypnozyte. Okay, and these different cell types is going to be indicative on what stage of the life cycle the malaria virus is in, or the malaria protozoa is in. Okay? Now, what's the clinical presentation of a patient who has malaria? Just like the case indicated, the first primary signs and symptoms are these flu-like symptoms: low-grade fever, myalgia, malaise, headache, chills. Once the malaria enters into the erythrocyte, there is a whole bunch of different phases that the patient goes through. And this usually is every 24 to 48 hours, it will rotate through these different phases of infection. So once the patient presents with this low-grade fever, chills, influenza-like symptoms, once it enters into the erythrocyte, you can get this stage first, which is called paroxysm, where the patient ends up with a high fever and chills and rigors. Does anyone know what rigors are? Chills. Shaking chills. Okay, so the patient enters into this stage first, and then after that, they'll enter into what we call a cold phase, where they become febrile, and all of a sudden they become very, very cold. And they end up with pallor, which is loss of color in the skin, cyanosis, which is bluish color of the lips, and ends up with goosebumps, secondary to the cold phase. Soon after that, they end up with what we call a hot phase, where their fever becomes very, very high, almost 105 plus. And after that phase, they enter into the sweating phase, where the fever resolves because of vasodilation of blood vessels in the skin. So they rotate through these different phases every 24 to 48 hours, and it's generally around this time where the patient seeks treatment. Because generally up to this point, these low-grade fevers and influenza-like symptoms can be just misdiagnosed as any type of flu. And then what I mentioned, if you end up with this type of strain, this falciparum strain, which is the most dangerous and widespread, this is the strain that most likely will lead to death if not treated. So it's very, very important to obtain the